So this is a presentation about the Cartesian study. Cartesian stands for COVID-19 effect on arterial stiffness and vascular aging. And the principal investigators of this project are me, Rosa Maria Bruno, and Pierre Boutoury. We are working in Paris at the Institution of Medical Research in CERN. This project was developed inside a scientific committee from the Artery Society, and we are conducting this research with the support of the cost action VascAgeNet. This is the reason why now we are presenting this project to all of you. So just to summarize the study hypothesis, we hypothesized that COVID-19 could be a mechanism of vascular aging. So in this scheme, you can see different factors influencing the biological vascular age, that it could be quite different from the chronological vascular age. And we hypothesized that this infectious disease, COVID-19, may have some direct effect on vascular aging because of many reasons. First of all, this virus is able to directly infect endothelial cells. Its receptor is ACE2, which is a very important receptor controlling the renin-angiotensin pathway. And the infection from SARS-CoV-2 virus cause a decrease in ACE2 function. So the virus enters the cells by this receptor, and this virus is reducing ACE2 activity. It means that the renin-angiotensin system becomes unbalanced. So the effect of angiotensin II are not counterbalanced by the effect of angiotensin 1,7. And this, of course, is a mechanism of increased inflammation, oxidative stress, vasoconstriction, and it's a mechanism of accelerated vascular aging. We recently read on Lancet about the direct proof of endothelial infection from this virus. And also, this is particularly striking for the myocardium. Initially, the hypothesis of myocardial involvement on COVID-19 was myocarditis, but indeed, it seems that the endothelium component could play a major role also in myocardial damage. But this virus may impact the cardiovascular systems in many ways. And one way is systemic inflammation. We all know that autoimmune disease and chronic inflammatory diseases are associated with increased accelerated vascular aging, and this virus causes a massive inflammation which can compromise vascular function and structure. Another mechanism is more psychological, and the infection from this virus, especially in the severe form associated with the intensive care unit assistance, could be another risk factor too for increased vascular aging. Just to explain these two mechanisms, you know that, of course, you know very well that inflammation is a major driver of arterial aging and stiffness by acting on many different targets, smooth muscle cells, vascular calcification, and elastin and collagen fibers, and the endothelium also, very, very important. And maybe less known is the correlation between early vascular aging and the post-traumatic stress disorder. You can see on this slide on the right some graphs from a paper in a research conducted in individuals deported to Siberia when they were children, and these people had an increased risk of cardiovascular disease. And one of the major determinants is the presence or not of post-traumatic stress disorder. And also the pulse rate velocity is increasing with the increased severity of the post-traumatic stress disorder. Then we have a sort of bidirectional relationship between COVID-19 and cardiovascular disease, because indeed many cardiovascular risk factors who are inducing accelerated vascular aging are also impacting the prognosis of COVID-19 disease. So, for example, obesity, diabetes, male sex, and low socioeconomic status. These factors are all associated with a worse prognosis from COVID-19. There are many papers that are coming out exploring the role of cardiovascular comorbidities on worse COVID-19 prognosis. This is just some examples. So this is why we believe that measuring arterial stiffness in COVID-19 survivors could be an asset, could be an advantage for this patient, because we will be able to quantify the vascular damage associated with this disease, and so then we can improve patient management in this way. So the primary endpoint of our study is carotid femoral pulse rate velocity, which is, as you all know, an established biomarker of early vascular aging. We are going to perform these measurements on COVID-19 survivors 3-6 months after the infection, and then again 12-15 months after the infection. The design of these studies include several measures, not only carotid femoral pulse rate velocity. We decided to have a rich panel of measurements. Each center may adhere with a different panel of measurements. The most important thing is to have a standardized way of measuring these parameters, but we encourage all centers to perform multiple tests on these individuals. So we have added the measures of central hemodynamics, and we will perform some post-processing analysis to derive wave separation, wave intensity parameters. This is very important to understand the crosstalk between the microcirculation and the macrocirculation. And we encourage the centers who are equipped to do this to perform a flow-mediated dilation in the brachial artery, because it is a non-invasive and very useful marker of endothelial dysfunction. And of course, if it's possible, we encourage all the centers to add also 24-hour brachial or central blood pressure, measurements of carotid geometry and distensibility measured by ultrasound, but also of smaller arteries if available. And also the arterial ventricular coupling is very important. So if possible, we ask to collect the data about cardiac ultrasound too. Of course, some of these patients, those ones who are admitted to a medicine ward or to intensive care unit ward, they perform also thoracic CT. In this case, it could be possible to have an idea also of aortic calcification. So we will try to answer several research questions. So the protocol will include several measurements for that reason. The first one is EVA dependent on COVID-19 severity? This is why we will enroll both patients admitted to general medicine ward, patients need hospitalization in intensive care unit, but also patients not requiring hospitalization, in order to have an idea of the relationship between early vascular aging and disease severity. in order to understand if the infection per se is associated with early vascular aging, we planned to have a control group too. So individuals who came to the emergency department for suspicion of COVID-19 infection, but with a negative test. So we encourage all the center to recruit also a negative control group. Another question that we would like to answer is which role for psychosocial factors such as the post-traumatic stress disorder, but also the socioeconomic status in the COVID-19 induced early vascular aging. Which role for previous chronic or acute treatments? This is really a burning question. There are many reports about protective role for ACE inhibitors, for example, but also a suspicion of adverse effect with this drug. So it is very important, and we perfectly know that RAS blockers are de-stiffening drugs. So it will be very important to acquire medical history of these patients to understand their treatments. Of course, the role of comorbidities or pre-existing cardiometabolic disease will be very important. We need to ascertain if accelerated vascular aging induced by COVID-19 is accelerated in the presence of pre-existing cardiometabolic disease. And we encourage all the centers to keep track of these patients even after the end of the Cartesian study in order to set up a clinical follow-up during 10 years. This is very important. It could be done simply with electronic medical records. We don't need to recall all the patients, but to keep track of these patients in the future years will be absolutely useful. And this is the power of having a large cohort and a multi-center cohort. So as already said, we will enroll 4 different groups. 3 groups with recent confirmed infection, and but 1 group hospitalized in intensive care unit, 1 group hospitalized in a medicine unit, and 1 group not requiring hospitalization, and a control group and with a negative control group. This is the study design. So you see that we have 2 visits, visit 1 and visit 2, which are identical with the pulse rate velocity and central hemodynamics performed in all centers, and then optional additional vascular tests such as flow-mediated dilation, carotid and cardiac ultrasound, and some psychometric tests that could be done for, by self-administration to the patients. And of course, it will be very important to have to collect cardiovascular event and mortality in this cohort during the following years. We think that will be useful to have a different assessment of the cardiovascular events at 2, 5, and 10 years. So in this slide, you can see the Cartesian Consortium structure. So me and Professor Buturi, we will act as the PI. Then we will have the scientific committee, which is responsible of the scientific content of the protocol and publication, and will manage future requests for additive analysis on this database. And we will have national study coordinators. We decided to have 1 national coordinator for each country adhering, and to perform in parallel in the different countries the submission to the ethical committee in order to make the procedure as smooth as possible. We will have a centralized electronic CRF, which will be based on the RedCap server at INSERM in Paris. And all the centers are asked to fill in the electronic CRF on their server, and the results will be collected by our server. Of course, each center will have access to its own data. but the analysis will be centralized. We planned to collect all the raw data, especially regarding central blood pressure waveform, in order to perform the wave separation and wave intensity analysis. And we established a consortium, which is, so each one already decided to participate as signed an authorship and publication agreement. And our policy for publication is to have all the researchers as authors, so to sign all the papers as a consortium. At the moment, the protocol started the submission protocol to the ethical committee in France, and I know that even in Italy the procedure is well advanced. We received a manifestation of interest by more than 30 centers, and the number is continuing to increase day by day. And we have at least 12 countries, and with the planned number of participants of which are going to be more than 2,000 patients. We were quite lucky, thanks to the VasquezNet network. 3 companies offered devices or software licenses for the time for the study duration to centers who have not already their devices, and the Artery Society offered a seeding budget for each centers. The exact amount need to be established because, of course, it depends on the number of participating centers, but it will be more or less up to 5,000 euro per center. So it is it is not covering, of course, all the cost of the study, but it will at least allow to cover the management fees, submission to the ethical committee, and this kind of expenses. We are encouraging all the centers to apply to national grants, and this is what we are doing in France. We are applying to a grant of the l'Agence nationale de recherche, and in UK a submission to the British Heart Foundation is ongoing too, in order to support as much as possible this project. So if you want to have more information and adhere to the project, you may fill in the online form that you will find at the link you are seeing in this slide, or simply on the Artery Society website. So my brief presentation is finished. So I thank you for the attention, and I will be very happy to receive your questions.
Hello, Bruno. This is Yeşim Tunçok from Turkey. Do you hear me?
Perfectly.
Mm-hmm. Yeah, this is Yeşim Tunçok. I'm the professor of pharmacology in 9 Eylül University, Izmir, in Turkey, and I'm also the director of the Turkish National Clinical Research Infrastructures Network. It is called TUCRIN. That's why I would like to get a detailed information for participating this study in this study in Turkey. For example, many centers, a couple of centers, for example, 9 Eylül University, but we are not a member of the Artery Society. Is it possible to be involved in this research without member of the society?
Yes, indeed, of course, we encourage the largest possible participation. The only limit is, as you see, we decided, the Artery Society decided to give a small budget to each center. And so this part is only for artery members. But of course, you can join the Artery Society at any time, so it's not a problem. And you can adhere to the Cartesian project even without being an artery member. The limitation is only for this budget.
Mm-hmm. Okay.
So please fill in the form, and you will receive the summary of the study, the authorship agreement form to sign, and I think that we will have as a deadline the end of May to collect all the adhesion, because it's really time to start. Luckily enough, the first wave of the infection is over in most countries in Europe. So it means that to perform the visits 3-6 months after the infection, we have to start end June. So this is why we are closing the possibility to adhere at the end of May, in order to start with the ethical committee approval and start as soon as possible the recruitment.
Another question for you. Is there any requirement to be a researcher from Turkey or from another country? For example, a physician or pharmacist? Is there any requirement?
Not at all. Most important thing is that whatever your profession, you have the possibility to see these patients and to perform the measurements. So this is, of course, you can involve other researchers in your institutions. You can then, because we decided to have this kind of structure, which is very flexible. So we will have a different. We will have different national studies going on parallel. So each country in some way should be connected with us. We will provide all the material for the ethical committee submission. You will be only in charge of making the study work in your country, and also to translate the site-specific documents in your language, of course.
Okay, thank you very much. And how many researchers will be in one center? For example, one cardiologist, one pharmacologist, and one thoracic, for example, internal medicine specialist or something?
No, absolutely, you may involve other people, no problems at all.
Okay, okay, thank you very much.
You're welcome.
Hello, Rosa Maria.
Hello, Anna.
Sorry. So just a quick question regarding control. Is it necessary that we collect them from the emergency department and that they were tested negative? Because it seems that we will have a hard time getting this control as opposed to just normal control.
The problem is you perfectly know that this infection could be asymptomatic. So we need, in some way, a piece of evidence that these people never get infected. This is why we decided to have a strict criteria for this. Of course, it's we can a person who was negative 6 months ago may become positive. May get infected later on during the follow-up, but in this case, we believe that the crossing between groups, it will be at least limited. It will not be perfect, but at least limited. And the only possible, because since now it is difficult to set up a study with the serological testing at each visit for many reasons. And so we think.
And they also can be negative. So once again,
they are false negative. They are false positive. So at this moment, we decided that this was the maximum level of security that we will have to have a group of controls.
And you said you will provide us with all the ethical committee materials.
Yes, we prepared all the informed consent, the protocol, the CRF in English. So the only important thing is that then each center should proceed in translating the site-specific parts, so the informed consent and the questionnaires for the patients. The rest, usually in English, it's okay.
Okay. Thank you. That's.
One important thing indeed, some of the questionnaires are a standardized scale. For example, for the diagnosis of post-traumatic stress disorder, there's a 20-item scale. If possible, in these cases, we should use the validated version of the questionnaire. So you should, you can find if the questionnaire was already being translated by a professional in your language, and you can find the relative publication and use the validated version. This is quite important for the standardized questionnaires.
Hello, I'm Tommaso from Trieste.
Hello.
From University of Trieste. My responsible, Andrea Grillo, already signed up for participating in the trial. We would like to ask if we can use Pulse Pen instead of Sphygmocore, because we have the equipment in Pulse Pen edition.
So for the pulse wave velocity device, we decided to stick with the validated device. So at least a Sphygmocore, Complier, and Pulse Pen could be used. But the list is limited to these three, and we will not accept different devices from these three.
Oh, okay, we have Pulse Pen equipment, so that's why the question.
The problem is that if you use Pulse Pen, you will not contribute to the wave separation, wave intensity analysis, because this part will be done only with the Sphygmocore device. Because from the survey that each center already completed, we know that the majority of the centers have the Sphygmocore device with the validated transfer function for aortic pressure. And so this part of the analysis will be done only in this center. So if possible, we always encourage to use this kind of devices. Yes.
Okay.
But we accept for pulse wave velocity also Complier and Pulse Pen.
Okay. Okay. Thank you.
And then all the centers will be provided with a document with the standard operating procedures. With the specific instruction how all these measurements will be conducted. So very important also is to have a validated brachial blood pressure sphygmomanometer. This is quite important too, of course.
Of course, yeah. So, yes, we have a hypertension center, so it's okay.
Perfect.
Thank you.
Good afternoon, Rosa Maria, and all other participants. First of all, I would like to congratulate regarding the idea, and as a cardiologist, I am also deeply involved in theoretically regarding the cardiovascular consequences of COVID infection. But my question would be that, yes, I absolutely understand your restriction regarding the carotid femoral pulse velocity well-established and validated devices. But in the secondary endpoints, there are other parameters and other techniques. And if I'm using only the oscillometric device, which is absolutely suitable for 24-hour brachial and central blood pressure monitoring, I could contribute to the secondary endpoints as well. But you mentioned that some of the participating companies could give such devices like the Sphygmocore or Complier. Is it possible to get for the research? Because I would be very interested in. Yes, you know, in Hungary there was a much more lower rate of infection, but I think it can be collected because we have more than 3,000 confirmed cases, and I would like to recruit them from the other parts of the country. And as a not only a cardiologist but a clinical pharmacologist, I would be very happy to be the national coordinator of Hungary and collect the other centers, maybe the centers from the capital, because it was much more infected than the countryside in Hungary. Mm-hmm. So that's all I would like to add.
So as of course, this is important for us. So I will collect your name in the list of people who would need a SphygmoCore device, and so we can see if we may provide a device for the duration of the study.
But to be honest,
I think we have in the call some representative from EdCore. If they want to directly speak, to give their opinion, it will be even better.
Yeah, okay. But I'm using SphygmoCore XL for central blood pressure measuring, but it is not suitable for pulse velocity as well, because I got it for a Bayer study, which is investigating the effect of a vasopressin antagonist on central hemodynamics, but not for pulse velocity. So I have the part of the validated device, but I would need a standard carotid femoral pulse velocity equipment. So yeah.
Okay. We will try to support your center too. We will do what we can.
Okay.
Dr. Bruno, this is Doug Kruszinski from AdCore.
Perfect. Nice to hear from you.
Well, it's nice to talk with you. One thing I would like to caution is when devices are provided by drug companies for clinical trials, as was just mentioned, they really must only be used within those trials. Having said that, and back to your earlier point, please do capture information about those who require devices. As I mentioned when we communicated by email last week, there are issues with distributors which I'll need to review, but we'll do what we can to facilitate this important study.
Mm-hmm. So thank you very much for this offer, for intervening now. I'm filling in this list, and we'll provide you the list as soon as we will close collecting new centers. So end of May, in 10 days. So
thank you.
If you want to start taking some contact, maybe I can provide already the list, the temporary list that I have that can be updated at the end, as you prefer.
That will be fine if you'd like to do that.
Mm-hmm. Okay, great. So this is, I think, one of the most important side effects of having this Vasquez net in place in this moment, because it was really important to have already. It is very important, I think, like the things that we are seeing now, that we are really able to connect research centers with the industry for reaching an important objective altogether. Are there any other questions?
Hello, Rosa Maria, can you hear me? This is Maria Perisio, I'm from Portsmouth. We spoke briefly via emails. Thank you for your lovely presentation. It was really good to hear. I just have one question to specify one parameter. You mentioned that one of the recruitment criteria is to get patients that they had COVID 3 to 6 months. Do you mean from diagnosis or from treatment?
From diagnosis. We decided to have as the beginning the diagnosis, and we have decided to have a large window, which is a 3 to 6 months, just to make sure that we maximize the recruitment. So I hope that we will really succeed in achieving this objective.
Mm-hmm. That is great. My second question is kind of procedural. Do you think that these measurements can have to happen only in a hospital setting, or can happen into a university setting as well? Is that safe?
I think that it really depends when your vascular lab is situated. So the local organization is really up to you and to the rules of your organizations.
Okay, yeah, that's fair enough. Thank you.
You're welcome. Are there any other questions? Okay.
Could you send the slides, please, to me, to us?
Yes, of course I can share the slide. I think the most I think okay, we will share through the mailing, through the VASCAGE mailing list.
Thank you very much.
And I also recorded all the presentation, so maybe we can make everything available if you want.
Oh, that's good. That will be good. Thanks.
You're welcome. Okay, so if there are no more questions, I really would like to thank all of you to spending with me these 40 minutes, and I really hope to have convinced some of you to participate to the study. I know that we are, how can I say, we started a lot with our enthusiasm. So we set up a project and we are trying to fix all the stuff going on. This is going a little bit like this, but it will be really a pleasure to continue this path with all of you. So thank you for the attention, and so stay tuned for the next developments. Bye.
Bye. Thank you.
Yeah,
Bye.
Thank you.
Thank you. Thanks.
Thank you. Bye.
Bye. Bye.
Bye.